My name is Lisa Bertola. I'm a benefit consultant at Siegel. I'm head of the Boston office there. I live in south of Boston, Massachusetts, where I work with a lot of large multi-employer Taft-Hartley group health plans and large public sector group health plans, as well as corporate employer private payers. So I have become an industry subject matter expert on substance use disorder because my clients have been so hard hit with opioid epidemics and alcohol use disorder. And at Siegel, we study the claims data and look at what the impact of those co-occurring issues, chronic issues, have in terms of claims experience. And for instance, we see that for someone with alcohol use disorder, at least 3+ times the average medical and prescription drug costs. Someone with opioid use disorder, it's north of that. And there's a lot of safety issues. Again, I work with the building trade, so there's a lot of human suffering, a lot of families affected by this, and it's a very interesting, challenging issue because it involves regulations for the safety-sensitive occupations, but it has impacted human life in my corner of the world and with my clients in a very negative way. And yet we have lots of science, lots of data and technology, but we haven't really fine-tuned the solutions collaboratively, and I underscore collaboratively, to get the best solutions at the hands of the people that need it most. So I wanted to share just that with my background. We have Bob from Hazelden Betty Ford, Chief Commercial Officer, Jen Shugman from Care First, Deb Adler, CEO of Navigator Healthcare, and John Driscoll, CEO of Care On Recovery Centers. So a wealth of expertise here. I'm going to queue up a few questions for each of these panelists. I'm also going to welcome your questions using the online tool that we have. You can scan the QR code and enter your questions on slideco.com. So I will be looking at those at the end of this presentation. But just to throw out real quick something to food for thought and how this would bring the conversation together with all these varied forms of expertise. Substance use disorder, we talk about the disease, but before there's a diagnosis, we know that mental health and substance use disorder are typically undiagnosed, but there are symptoms for 10 to 11 years. The lag time before a medical diagnosis for this disease is 10 to 11 years. Those individuals are out working, they're in the workforce, and they're functioning. They're among us, they're our friends, our peers, our family members. So we're not getting ahead of this disease from a prevention standpoint well enough. I'm going to queue up the next question for Bob, because I'd like to know from Bob, with all his experience at Hazelden Betty Ford, one of the nation's largest centers of excellence for treatment of substance use disorder, what is it that plan sponsors and employers could do to get ahead of this more proactively and help with early detection and destigmatizing this disease?
Thank you, Lisa. Hi, everybody. When we talk about the partnership in care, I think it has to start with the whole concept of partnering, but I think we have to bring the employer into it as well. As we look at managing health, creating healthier workplaces, and taking the competitive advantage that happens to people in recovery. I just saw some numbers the other day that really surprised me. I didn't realize that we as a country spend more money managing chronic illnesses than we spend on our national defense. And that most of the healthcare costs are actually paid by employers, not the government. And that employees trust their employer more than the government for healthcare directions, and the person they really trust within their employer group is their manager. But you think about the role of stigma. 60% of us have a chronic illness today that drives up healthcare costs. 90% of all that cost I talked about, almost $4 billion is spent just on managing chronic illness. 60% of us have a chronic illness. 40% have two chronic illnesses. And when one of those is behavioral, the cost goes up 10%. So when we're looking at how do we manage, create healthier workplaces, stigma plays such a huge role with it when it comes to mental health and substance abuse. And what we know now is that the people that are returning to work post-COVID are not in the same condition they were before they left for COVID. They're much sicker. EAP called it the most trying psychological period in our history. So I think that partnership I'm talking about begins with payers, benefit consultants, and employers recognizing that now is the time to finally get out of the weeds and keeping your head kind of below the table, not being willing to discuss the reality, which is 70–80% of the people who are struggling with substance use and mental health are employed full or part-time. And it shows up in the workplace. And it shows up when we're addicted. Every way within cost, we're like those addicted employees are 5 times more expensive, they miss work more, their workplace accidents, workplace violence, etc. But we're starting to get some data now that talks about those in recovery and the return on that investment. I think it's really important. I'll share a real quick personal story. I lost a career of a Fortune 200 executive through my cocaine addiction. I got sober, and in a meeting one day, somebody said they recruited me to go back to work for them. And the person said, Bob, we know all about you. And I said, well, you don't know all about me. And I said, there's a story behind my use. He goes, no, we know all about you. My dad said, if you ever hire a man in recovery or a person in recovery, do it because their life experience will produce a better employee. I thought it was a good story. That just was a good story. But recently, there's been a lot of research done on this, and as part of the United States Department of Labor's Recovery Ready Workplace Initiative, where they're studying those of us who are in recovery and how we are as an employee. And what the data shows, too, is that people who are in recovery are not only better than they were when they were using, but they're better than people who aren't addicted or aren't struggling with substances because of their life experience, because of the resilience, because their sense of purpose now is about recovery, and work plays into that. So the Department of Labor, not the Department of Health, actually launched this initiative to create workplace recovery-friendly environments. That was started with New Hampshire. Minnesota just announced a couple weeks ago that they were going to support a recovery-ready workplace environment that supports recovery in the workplace. And not only recovery, but access to care, access to benefits, and work to destigmatize substance use in the workplace. Because, number one, it makes sense when you consider that most of the people who are struggling today are employed. One out of every 3 of us is impacted somehow, directly or within our family. And it's a huge cost. But the Department of Labor thinks it's a competitive advantage to be able to recruit, retain, and differentiate yourself in the workplace. So I'm hoping now that the tide has changed. Our first ad as Hazel and Betty, we just celebrated our 75th anniversary. Our first ad that we ran trying to get employers to look at substance abuse was 1953. We had 2 ads that ran in the Minnesota newspapers that says if alcohol affects your employees and we support recovery in the workplace. In 2020, we launched a big campaign in New York, started in New York, called Make Recovery America's Business. And quite frankly, those didn't go anywhere. The employers were not ready to address it. But what I'm seeing now, Lisa, through the work that you're doing, some of the work that we're doing with some of the payers, is we are putting together strategies that look at destigmatizing addiction, bringing peer support into the workplace, providing management training, creating centers of excellence program where people are able to get steered to those providers that make sense. And I think they're showing promise. My colleague here from our publishing department, Joe, is here, and we spent over a year taking all the content that we've had as a publisher recently and created a portal for workplaces called Wayfinder, which allows employers to easily launch a digital solution into the workplace to start to provide access to care for those people who might be afraid to access care by creating them an anonymous tool to start. They get some education, they get some screening, which is really important. And hopefully what we'll find in this whole process is that we make addiction, the disease of addiction, as common as any other chronic illness as far as people's willingness to look for help, to provide those same tools, those same interventions, those same resources to access. And then when in their recovery communities in the workplace, that we could create these peer environments, those interpersonal relationships that are so important, that we could promote recovery and kind of get out of the dark ages and get into the current healthcare stage.
And I agree. I come from a multi-employer background at Siegel, and I would say that the building trades and a lot of the large collectively bargained groups knew that a grassroots effort had to do that first to kind of get the word out and to destigmatize. But formalizing it with these templates and the DOL's involvement, getting the government to give folks a blueprint, and Hazelden has great resources as well, really helps to destigmatize the conversation in the workplace and set things up so that when people need care or treatment or education, and that'll segue now to Jen, that they're ready to understand with at least a base knowledge of the symptoms of this disease, the factors, the challenges of engagement, and the fact that it needs actually a community of support, whether it's peers or family or community-based resources, in order to get someone to engage with evidence-based treatment. So Deb, I'm wondering at Care First, I'm sorry, Jen, I'm skipping. Jen, at Care First, can you explain what success Care First has seen with technology and virtual care and the ensuring engagement and adherence to treatment along the full continuum?
Absolutely, it's a great question. Thank you so much. The fact that we're having this conversation is amazing, and we need to have more of these conversations together. So my name is Jen Shug. I'm the Director of Behavioral Health at Care First. I'm a licensed clinical social worker by profession. And so I'm going to talk about this issue from a clinical perspective and really our member journey and how we're helping our members access care. So typically, right now, like you said, the data that you've all provided, that's the landscape that we're working with right now. Stigma is a tremendous barrier for folks accessing the care that they need. People are afraid they're going to lose their jobs, they're afraid they're going to lose their families, their livelihood. And so you can see the bind where someone may need care. They may wake up in that morning and say, not today, I don't want to use that, I don't want to use, but they can't get care. And then once again, they're back in that cycle of using. Some of the things that we've done, and the reason I set it up that way is that we've got some technology partners that we've been working with that have been amazing, and they're helping our members access care, and I'll talk a little bit about that. But the human connection is the place. That conversation that you have with someone that you trust or someone that's knowledgeable, who you can say, look, this is where I am, this is what's going on, and they'll say, you know what, man, like, I got you. Let's go to a meeting, let's do this. And so those are the conversations. So from a payer side, from the clinical practice, what we're trying to do is make an easy access for all of our members to get the care that they need. So right now, if you need care, whether it's behavioral health or SUD, on the back of your insurance card, there's an 800 number. You call that number. On our phone tree, it is built in that you can select to speak with a substance use disorder navigator, Deb's team. 365, 24/7, when that person is ready to get into care, they speak with a live clinician who will do a motivational interview, and then they will actually schedule treatment for that person. And we're seeing folks get into care now within 48 hours. We have a cost share waiver program that we provide to our members. What that means is that if you access an intensive outpatient level of care, Care First will waive your copays for treatment. It's a tremendous barrier for folks when they have to go to care 5 days a week, 6 days a week, 7 days a week in their copays. For some folks, that's a barrier. Affordability is an issue where they won't access care. So we have made a commitment to our members that we're going to remove that for our folks. So we have 16 partners in our cost share waiver program, 48 locations where any of our members can access care and have those copays waived. And then we're really trying to work also with aftercare planning. So we're in concert with these programs, and we have a team of 16 licensed clinicians. And I did that work. I'm a 9-year at Care First, so my first job, I worked in a grocery store. I was the bagger, I was the grocery store, I worked in the bakery, and like Care First, like I was the care manager, transition of care, utilization manager, been there, done them all. So I understand. So I'm boots on the ground. So I know how this works, and I know where the points of failure are for folks. And so we've got a team of people who are available. So if you call our 800 number, you're either going to get one of our clinicians Monday through Friday from 9 to 5. After hours, we have an online service so you can get a clinician, and then you've got our navigator partners, and they're 365, 24/7. So if you're ready to plug into care, we're ready to walk beside you and make sure that you get what you need. And then we're going to follow up with you on an ongoing basis, and we're going to make sure, using other technology platforms like Headway, where you can actually, and if you're a clinician, you know exactly what I'm talking about. If you've ever done discharge planning from a hospital, has anybody done that? Has anybody done discharge planning? One person, 2 people. Okay, let me just tell you, love you. It's really hard. So like a long time ago, you would get a list from the payer of clinicians. And guess what you did? You called down the list. But this person's leaving the hospital, so you have to get an appointment for this person to get care. Well, tech folks, we love you, because what you've done is now you can actually go in, you can select an appropriate clinician, you can schedule treatment, and get into care. Right now, our members are able to access care on a mild to moderate acuity within 5 days. HIPAA-compliant platform. Claims go through the platform. People can pay their copays through the platform. They know what their cost is. These are things that have kept people from getting into care, and so we're really working on that. And then, what was the other thing I wanted to say? Oh, and then the other thing, sorry, I'm not a public speaker, I'm a clinician. I'm doing my best. And I'm getting there. One of the things that we're really working on also is we need to look at the workforce and our clinical workforce going forward as well. And so in Baltimore City, CareFirst has actually created a workforce development program at Mondawmin Mall. We've partnered with local providers there. We have 100 jobs coming online. And we're talking about this idea of maybe working with higher institutions of learning and creating clinical workforces of the future in exchange for supervision and CEUs and things like that. So we love the ideas. We'd love to talk about ideas and innovation and think about how we can solve these problems. But really, to the point, is really people need to feel safe that they can get the care that they need and plug in, and we need to be ready to take them and help them with that when it's time. And so that's what we're working on.
And look, one of the lessons from the pandemic was that virtual care, 70% or more of the virtual care that we saw for professional services was for mental health and or substance use disorders. So people do use technology to engage for these specific chronic conditions. There is additional confidentiality and privacy ensured when you can be mobile with your clinician or your care navigator. There are compliance issues, there are state regulations, there's dispensing rules around the medication-assisted treatment. We do have to keep all that in mind, so it has to be done smart. We do encourage folks to work with consultants just because it's a tricky landscape out there, and those compliance, cybersecurity issues, those are real. But that engagement, leverage of virtual technology and innovation for these specifically hard and challenging disease conditions, where, don't forget, this is the only disease where the individual with the disease has a fear of withdrawal and often has denial and often has not a willingness to engage with care. What other disease can you say that about? So this resistance to treatment and care and engagement is a big differentiator about substance use versus other disease conditions.
And Lisa, that point that you just made about telehealth is so important because we have folks in rural populations where there just isn't a provider network there. And telehealth has allowed folks to access care that otherwise would not have been able to get into care. So it is wonderfully helpful and beneficial to members to be able to access that. And if you're in particular in say Maryland, for example, if you're licensed in Maryland, you can see any patient throughout the state. And that's great because where we don't have a physical presence or where folks are not in that market, they can work with experts all over the state, in particularly urban areas and specialists and things like that to get the care they need. So it is absolutely, there's a synergy there between the people and the technology and really bringing the best out in that for folks to be able to get what they need.
Great point. Good to know you're doing hard work in the trenches with the carriers and the insurers because it's so important. So segueing now to Deb Adler, CEO of Navigator Healthcare. She works in sync with Jen at CareFirst. And so, Deb, can you go further on the use of digital technology and AI specifically and how it's a game changer for treatment of substance use disorder?
Absolutely. And I'll echo a little bit of what Jen said. At Navigator, we work with employers and payers to help their members get fast access to evidence-based treatment. And so we're working across all 50 states and trying to meet the member where they are, whether that's in person or virtual care. And it's interesting, the clinical deserts that exist. I don't know how many people know, but in Las Vegas, if you want to get an in-person alcohol use disorder treatment program, you're going to be out of luck because there is virtual available, but really a dearth of in-person programs, particularly for alcohol use disorder in other parts of the country as well. And certainly we all know that virtual has really helped open up access and allow individuals to get care that wouldn't otherwise, particularly stigma, whether it's an urban area or a rural area, you may not want people to know that you're driving down to the local treatment program. But I think I've seen good things, I'll say, with AI and machine learning, and some that concern me. From an AI standpoint, most of what I've seen to date is really focused on efficiency of care, right? Helping, and that's good, that helping the clinician, do their treatment plans, create their progress notes, taking transcripts from conversations with the member, and turning that into, at least, I'll say, temporary notes that can then be reviewed and acted upon. And so that does save the clinician time, but it doesn't always have a direct impact on the member, other than the possibility of spending more time with the member and less time taking your notes. I do see AI and machine learning as a great option for risk management as well. It can help identify, things that are said in a conversation that need to be addressed, and help the clinician really intervene more quickly. So I see some positives, but I think there's nothing to replace the high touch that's needed when someone has this condition, needs help with substance use disorder. That's why we have clinicians available 24/7, because you do need that trusted advisor. In fact, as I talk to folks that have been in recovery, they always talk about that one person, whether it was a peer, a boss, a family member, a friend, that was so pivotal, and I think you just can't replace that. So I anticipate, there'll certainly be some efficiencies gained through AI and chatbots and other things, including helping with care coordination and tapping people on the shoulder, making sure that you're staying engaged. Because we even know, we work with the member for at least 6 months after that initial connection, and sometimes they don't pick up the phone, but it is like having someone on your shoulder. And so we do find sometimes when we do connect that we were calling at that right moment when they were trying to decide at the airport whether to walk into the bar or get on the plane. So we know that it has an impact. So I would just say I think there'll be a pendulum swinging back, and it's not because I'm the oldest person on this panel, so I'm not anti-tech, but I do think we'll see a swinging back of people wanting that human connection, and we just can't replace that. Yeah. And the same with apps. I was just meeting with a large group of consultants, and they work mostly with union and labor, and the immediate reaction is our customers hate apps. And I don't hate apps, but we do know the data says that people don't stay connected to an app for very long. Right. Typically 2 weeks at tops. And there is that 5% that will stay connected for 30 days. But I think that's the thing to take into account is unless you have a peer, a buddy, a connection, in addition to that app, it makes a huge difference.
Yeah, and technology literacy of a particular group, I've run across that challenge as well. The one thing I would say about apps, and apps can be very useful from a human to educate, teach individuals. Misuse, abuse, the definition of substance use. They don't know. EAPs and member assistance programs actually can play a role there. And I would only say that apps can be useful in that space for early engagement education. And then it's even better when they can segue that, if you can segue and create new clearing houses for the claims of higher levels of care, when you have synergy between those entities, and it's not silo EAP, silo health plan, silo a center of excellence, when you have too many menu options and you're not collaborating, the cracks. I've been doing this for a long time, and you see wonderful solutions collecting dust on a shelf because no one is cross-referring, no one is, creating that collaborative conversation about, hey, if you just want general education, or for families for someone who is struggling with substance use disorder or approaching the disease state, they need to be ready and on their toes about treatment options, evidence-based treatment, the effectiveness of medication. There's a lot of community-based resources out there that talk about abstinence-only programs. You need to educate folks about their options and where maybe medication really plays a role and can be a turn-the-corner piece of a recovery plan.
So if I could just
Yeah,
add,
keep
I want to
going.
give Care First a lot of credit because they really do pay attention to the whole healthcare ecosystem.
Yeah.
They've helped, coordinate across their various vendors, the hospital systems, PCPs. They understand that interconnectedness, and I think that's made a huge difference in helping people get into the right care at the right time. And let's face it, a lot of individuals with substance use disorder are entering through crisis care, right? That's how they're getting in. And we have a lot of work to do to really get the word out so folks can enter, as you said early on, in a prevention stage, at an earlier stage.
Yeah. Thank you, Deb. So going to John Driscoll from Caron. John, it's substance use disorder is often considered that disease where the brain is hijacked. Are there existing technologies that can be used for my clients that want return on investment or evidence, they want to see what this investment will produce in terms of outcomes. They want to track patient progress. They want to see outcomes from a value proposition standpoint. What existing technologies are you seeing and using to help meet that demand?
Thanks, Lisa. Yeah, I appreciate it. What if we actually treated addiction and mental health like it was the brain disease that it is? How would we approach it differently than what we've been doing over time? How would we measure outcomes differently? One of the things that we're doing at care and treatment centers today is we're actually examining and assessing the brain. We're using the technology that exists today and other medical approaches, brain scans, brain mapping. We're looking at the electrical activity. We're looking at the biomedical issues and the hormones and the other chemicals that impact the brain to really say, what do we have going on here? We heard earlier in the conversation a little bit about how stigma, denial, minimization. What we're able to do at Caron is actually show individuals here is not just a normal brain and a brain on drugs, but here is a normal brain and here's your brain. And we're able to show it in color where we can show here's an area of activity, overactivity, here's an area of underactivity. And we can pinpoint what's happening in there. And we can identify through multiple waves of where they're functioning that say, here's the overactivity, that activity that keeps your mind running through the night, that compulsive behavior. And here's sort of that underactivity. We can measure some of the hormonal levels that are actually talking about, I get that panic attack. I get that expression of fear and guilt. I have that trauma response. People usually talk about how it's impacting them, and they grab their heart, even as I'm doing right now, as though this is a feeling disease. And we reach for our heart, but actually it's the limbic system. It's up here. Now we're foolish if we grabbed our heads, right? So I'll keep grabbing my chest and talk about the heart of the disease. But what if we actually today use the technology that's in existence to measure what's happening with the brain? When we talk about outcomes, one of the things that we do is we can show a patient, here is what your brain looks like, in true color, in detail, that helps explain what they're thinking and feeling. Our experience in doing this for almost 8 years is that stigma starts to wash away. They have answers. They thought, I knew something was wrong. I knew something was going on, but I couldn't figure it out. What if we actually showed them the data, and said, this is explaining it. And then we start to use therapies that address the healing of the brain. Now, in many ways, we've been doing this for years, but we haven't been measuring it. When we talk about abstinence, okay, that's simply stop the assault of neurochemicals on your brain from external substances. and allow your brain to return to homeostasis. And then when we're able to do that, let's see where it is. Is it producing the right hormones? Is it producing the right levels? We can actually see a trauma response occur in the brain when we watch it. And then we can use digital therapies to help disassociate that pathway. That feeling when somebody gets a trigger event, and today trauma is all over the place. When there's that trauma triggering event, we can actually see that occur in the brain. Well, what if we could desensitize them through non-invasive procedures to impact how that works? And then what if we were able to measure that? One of the challenges I have for the mental health field and the addiction field and the payers is to say, what if we talked about outcomes by being able to do this scan at the beginning, understand where they are, and then as we work our therapeutic treatments, let's measure those outcomes. Have we seen a drop in cortisol, in the stress hormone, come through? Have we seen a reduction in some of the overactive areas of the brain or the other? We took a young girl in, just to give you a quick example, she had overdosed twice, but lived. But she came back with the hypoxia so bad, she could barely function, okay? She looked like she was 24 years old, but when she put lipstick on, she'd smear it on like a 3-year-old would put it on. We actually utilized hyperbaric oxygen therapy to help restore the brain health. We did neuroplasticity testing with R bands that shows she was functioning 2 or 3 standard deviations below normal. And after 20 hyperbaric chamber treatments over a 20-day period of time, those scales returned to normal. The scans were nearly normal. It put her in a period so that her brain was ready to get the therapy she needed to continue. That's what I think we need to do as a field. And I think we need to have that paid for by insurance. If I walk out of here today, slip and fall off these steps and bump my head, number one, I'm going to go to the hospital. They're going to take my blood and they're going to test to see, was there an infection? Was there high blood sugar? What caused me to fall? And then they're going to say, what happened as a result of it? They're going to scan my brain. They're going to see, was there a bleed? Did I cause a bleed? Right. Is there a tumor? What's occurring in there? And all of that will be covered by my health insurance. Yet, do we cover these simple models that are available for mental health and addiction issues? And we talk about measuring outcomes. Let's join the science. And so that's one of the things that Karen is doing. The technology exists. We didn't create it. We are using it that others are out there. We are part of the research. Even here, we were just featured in one of the New York Times articles on GLP-1s that talk about craving. Our physicians are prescribing those because we are seeing a reduction. We need more studies into this, but this is where I think the future needs to be and where we need to start using the technology to advance the science of addiction treatment.
Yeah, thank you, John. This is great. There was a recent study of cancer survivor patients, and they were asked about when in their screening about substance use on a daily basis, et cetera. And the ones that responded that they reported, self-reported drinking more than 2 or 3 drinks a day, said the clinicians put information down, but didn't make any comments or referrals about potential risk for alcohol use disorder. So from using this incredible technology to, back to Deb's point about the human factor here, let's not forget the human factor. We need better training and better conversations about this disease and the risks it represents, how undetected it's gone, and better tools to detect it scientifically, not just GAD7, PHQ-9s. That's usually, as a consultant, what I hear from vendors. Oh yeah, we'll test outcomes, we'll have to ask a few questions. No, we have better technology than that to actually measure what's happening to the brain, what the progress is after XYZ treatment. We need to get a little more structured around this disease. It is disease discrimination. It really is. So to the extent we have this panel represents people that are groundbreakers, that are doing new and innovative collaborative things. Thank you to all. So John, you want to make some final comments?
Lisa, just one other point on that. So SAMHSA says 94% of the people that suffer from this disease believe it's a disorder they should be able to handle themselves. as we talked about the challenges of stigma, this is where I'm trying to turn it on its ear and say, it's a brain disease. It's an organ of the body. What other organ out there would we say we can deal with this ourselves? If you wake up in the morning and you've got blurry eyes and your eyes as an organ aren't functioning right, do you look yourself in the mirror and say, not today, today I'm gonna see in focus, right? But how many of us do that with addiction? No, because we think it's a moral discrepancy. We think that it's a personal weakness. If we can label this as a brain disorder as it is, let's get the assessment. You do it with your eyes and you'd get treatment. You'd get corrective treatment. You'd get glasses, you get contacts, you get surgery. We have all these methodologies to fix it, yet we don't do that with mental health and addiction. A big step in treating the stigma of this disease is to relabel it, rebrand it as a brain disorder.
I'm happy to take questions. We're at the quarter, I think we have about 10, 15 minutes left. If there are audience questions, you can do slideco.com and scan the QR code. But I think it's a small enough room that we could have you just raise your hand. Anyone have a question? Yes, certainly.
Hey, I'm Nick Allen. I'm co-founder and CEO of Sunnyside. We're an app focused on helping people get started on the path to healthier drinking earlier with kind of a self-guided and peer-supported system in your pocket. And I'm curious, a couple of the facts that stood out in the introduction were this kind of like 10 to 11 year period of time between, kind of being diagnosable and actually getting treatment. And then kind of the fact that a lot of SUD patients are coming in crisis to actually kind of getting care. What do we do about that? How do we kind of think about getting people started earlier, and what are some of the things that you've seen effective across the field in kind of, the early detection and intervention kind of side of the spectrum?
Can I start? Because I don't want to be the anti-app girl, and I love Sunnyside, actually, because I know you have a great app that really helps people that are interested in harm reduction, right? You don't have to quit, but you can monitor your drinking, and I think it's a great app, so I just wanted to highlight that. But I do think, I think Care First is doing some of this too, is you really just have to get the member awareness up that there are places you can call or work with an app that are private, safe, and confidential. And I think Bob talked about this too, is the employer could be doing more. I know they don't feel like, sometimes they don't feel like they should, and they're hiding some of the problems, right? And in terms of that underdiagnosis, right? It's like, oh, they fell or they slipped, but it had nothing to do with alcohol or opioids. So I do think there has to be greater member awareness that there are safe places that the employer is not going to know, but here's where you can get more help. Yeah. And I think there are, a handful that are doing that, and Bob probably has some examples.
It's a really good point. Our own research, Nick, every day we delay an admission, it's a 20% drop off in their willingness. Yeah. So if I can get you in the care the same day you called, 80% of the people get care, but every day it goes on, it's reduced. Because that moment of clarity that John talked about, today's the day, that I want to get help, but then something happens and now it's not a big crisis because I'm crisis driven. But I think the work that Deb's doing in the partnership with her payers is really important, because you think about this. This is the only disease that we really expect you to diagnose yourself. Mm-hmm. And then you got to try to navigate care. I love your company name. You have to go out there and go to Dr. Google, right? And most of the people that are really good at Google aren't really good at treatment.
Oh, it's worse than that. It's 2 a.m. and the ad for the recovery center, wherever, that's actually a predatory, center that's going to bill for lab work and unnecessary services. They'll even send a plane ticket. They'll pay for the travel. There is a predatory marketplace out there. So employers have a responsibility, and plan sponsors have fiduciary responsibility, my clients, to make sure that there is access to the information and the levels of care, even early detection and education, at the fingertips, and whether it's both apps and people, peer recovery groups in person, on the job site, recovery-friendly workplaces. But it is a predatory landscape out there, so when these folks are vulnerable, that's where the worst things happen. Yeah.
That's and also a lot of the work that we do is actually with the employers. So we do a lot of education where we actually meet with the employers and we talk about SUD and we talk about behavioral health and we talk about how to access these services. So to your point, there's an app, and we do education with that as well. But the biggest challenge that I see on the clinical level is people don't know where to go. They don't know where to go. And so we have to educate, and that's a technology issue. We can use it, and it's a people. We have to have these conversations. This is where it happens. So I'm really happy we're talking about this. This is how it starts.
Yeah.
So it's good
Before I
stuff.
ask a question, I wish the payers took a bigger role in steerage. I know it's always been a bad word, but not helping to direct these people to legitimate providers. We had an example, one of our states, we met with the payer, they said, you're 50% better than the average, which means you're really much better than everybody else. When I asked them, how many patients did you send us? He said, not one. It's like, how does that make sense? I think there's still more work that we can do to help navigate people to the right providers and get them more access to it.
And for any app out there, don't forget language. I work with groups that I worked recently with a multi-employer group. They had an entire local of Polish-speaking only workers. So toggling in languages, understandings, the cultural sensitivity, letting folks feel comfortable with who they're communicating with, and including that human element. I love peer-to-peer access through apps and technology because the American Society of Addiction Medicine recently, in their latest Continuum of Care update, recognized the role of peers with lived experience, not just clinicians. The clinicians are wonderful, but when you have someone who's in recovery speaking to someone who needs to get to recovery, there's a whole conversation pool of experience and words and shared moments that come into play that help with adherence and engagement. So it's nice to see ASAM updating their standards to make sure peer-to-peer recovery is part of that continuum of care. And any product out there, any thinking around substance use treatment, involving either the families, peers, other groups for support long-term, and access to virtual conferences or work groups, it really makes a difference. The building trades, my clients have been doing that for years with good success. They're quiet about it. This is a shameful, for that industry, it's a shameful thing to be dealing with high prevalence of substance use disorder in a safety-sensitive occupation. So it is somewhat stealth and underground. But if products and the mainstream healthcare system can also incorporate some of these best practices, that's collaboration, and that is the secret sauce. Yeah, please.
Thank you all so much for the fantastic panel. My name is Marlena Lira, and I'm an epidemiologist and researcher at Work It Health, which I'm sure many of you are familiar with, telehealth substance use treatment. I have a comment and then a question. The comment is in regard to the study that you cited, Lisa, about cancer and alcohol, and it just felt sort of ironic as you were talking about it that alcohol is actually a known risk factor for at least 7 types of cancers, including breast cancer among women. So just the fact that alcohol use was not discussed when it could have been one of the contributing factors in those cancer diagnoses. But my question is, John, for you about this expanding landscape for clinical outcomes. And I'm curious how you're seeing kind of the path forward to actually get payer recognition of these other types of technologies that could be used, and kind of FDA recognition of other types of outcomes, and kind of what you see as the pathway for the validation of other outcomes, and then from there, payer reimbursement.
Absolutely. Thank you for the question. So a big part of this does flow back with our research and our regulators to say, what are we doing with this? And as much as there's a stigma in the regular population, there's a stigma in how we treat this. It's a second-class citizen in many ways. And we've recently had some rules to say, let's treat this more parity. But we as providers, and that's the thing, we have our researchers. And I've been talking to a lot of brain neuroscientists lately. They speak at a completely different language. And what we've got to do is sort of unite us to say, research to practice, but practice to research. And to me, it just really clicked of this is a pathway around the stigma. Let's get access to care. and let's use the technology that's already in existence, that's already been approved and shown to be imperative, that says we can measure these items and track them over time. Even when we're prescribing medication, and I am for medication-assisted therapy, we don't do a lot of pre and post. Any blood test that we take is really to see, is the therapeutic level present in the body? We're not actually measuring, well, what is the outcomes? Have we seen a reduction in stress? Can we measure this in a way? And that would be my challenge, is to work with the payers, work with the researchers, work with the practitioners to say, let's treat this like a brain disease. We won the battle 25 years ago of we are a legitimate disease. We need to stop fighting the old battles and fight the new ones and advance the science of treatment.
So with that said, I wanted to thank all 5 of you for being up here. Last year we only had one SUD-focused session on at BHT, and this year we have a number of them, but I think all of you are experts in the field, and I think I can probably speak for the crowd here that it's been incredibly helpful. So when we look at next steps, what's the one thing that we can leave with? What's the one thing you want us all to leave with? And obviously it can be different from each person, but what's the one thing that's really important to you that you see changes? And what's the next step?
Do you want me to start with that?
Go, John.
And then we'll go from there. So again, what you've heard me say here is really, let's start treating this as a brain disease and ask the questions. Unite the field, unite the practitioners to really say, let's start using these blood tests, let's start using these scans to help us understand, assess, evaluate, and track outcomes in ways that the other parts of the healthcare industry are doing. And I know we've only got a short period of time here. If you want to talk more, I've got a great team with me. We're in booth 208 out there. Stop by and see us. We'll be happy to have more of a conversation.
Deb?
Oh, there's so many things I want. I guess I would say greater awareness and collaboration with employers being part of the solution. There's still a lot of bearing of information, and I think if there was just, a little more comfort in talking about this issue and looking at their own data, not down to the person, but an aggregate. And I think we'd come a long way in terms of acceptance of this as a brain disorder that needs to be treated.
Great. Jen?
I would say that, you don't have, my takeaway for everyone, you don't have to do this alone. You don't have to figure this out on your own. There is help out there. So whether you're going to access recovery through there are apps for recovery, or if you have a payer, I would encourage you, most payers do have care management programs. You can access that. Care First we do. Our number is on the back of the card. You can call us and we will help you. We have a team of clinicians. We have partnerships with tech companies, and we really are invested in making sure that people get the right care at the right time. We do not want people to wait. The days of you can't have care, that's over. We want you to get the care that you need when you need it before things get worse. You have better outcomes. It bends the cost curve. Folks have much, much better lives, quality of life, and that's why I'm here. So thank you.
And I guess mine would be whatever your scope of influence is, and what you all bring to the table today is to help kind of talk about what Nick talked about, which was to help us reduce stigma in a way that more people are willing to look for help, and then when they are looking for help, that they get navigation help and find the right providers. And I think for all of you who are providers in some form or another, that you look at your continuum and that you create the right partnerships with other providers that are legitimate evidence-based providers that can provide a continuum so that we can engage those patients over the long term, which is really one of the secrets that your network has expanded through the partnerships as well. And if I had one other wish, it would be that primary care looked at this seriously.
Yeah, absolutely.
Only 1 out of 10 people that go to a primary care physician with substance use will get diagnosed and referred, compared to 85% with other conditions. So there's a
Absolutely.
big-